Bismillah ar-Rahman ar-Rahim. Today I will speak about an important issue in clinical practice, which is the approach to management of patients in clinical practice. We all know that the approach to management of patients in clinical practice is one of two things. Either it is what we call conservative approach or what we call aggressive approach. The conservative approach is used mostly or usually in patients with chronic diseases and patients who are sometimes subacute cases. We use the conservative approach that is in cold cases, or what we call in cold medicine. We should be more conservative. We should not be in a hurry. We should not rush in taking a clinical decision. We should be more at ease and more wise in approach of the case, and maybe we have to put the patient under observation, which I mentioned before. It is the art of medicine. Under observation is the art of medicine, and under observation sometimes is the only drug and is the best drug to resolve the case and to reach to the proper clinical decision, because the case may settle down and become okay with time, and just what is needed is to put the patient under observation till, as we say, God calms the patient and cures the disease, or as we say, that nature cures the disease. And the role of the physician is to entertain the patient and to reassure the patient and to advise the patient and to observe the patient, to put him under observation. And I mentioned observation before as one of the clinical skills used in clinical practice or in clinical medicine, under observation. So, and under observation means time. That we give the patient time for diagnosis, and we give the patient time for taking the best therapeutic approach to this, to his clinical condition. And this is the art of under observation, which we use it in the conservative approach to management in clinical practice. Just we have enough time to investigate the patient and to ask for different diagnostic tools in order to reach to the probable diagnosis and then to the definite diagnosis, because we have what we call provisional diagnosis and differential diagnosis, and then after putting the patient under observation and the completion of the proper investigations in the individual case, whether laboratory, whether radiologic, whether endoscopic, whether other interventional diagnostic tools, we will reach to the definite diagnosis, and then we can proceed to the proper therapy or the proper treatment of the case. Because if there is no diagnosis, there is no treatment. Or if the diagnosis is wrong, the treatment will be wrong. So we have not to be in a hurry, we have not to rush, and we have to be more conservative in management. This is in cold cases and in semi-acute or subacute cases. In acute cases or in emergency cases or in urgent cases, the issue is different in clinical practice, and here we take what we call the aggressive approach, that the physician has to be more decisive. The patient has to take a decision more or less quickly, and to identify the exact acute medical condition the patient is suffering from. For example, like in hypertensive crisis, or in patients with acute pulmonary edema, or in patients with hepatic encephalopathy, acute fulminant hepatic failure, or in patients with acute renal failure, or in patients with hypertensive encephalopathy, or in patients with malignant hypertension, or in patients with diabetic ketoacidosis, or hyperosmolar hyperglycemic state, or in patients with thyroid crisis, or in patients with pituitary crisis, or in patients with acute metabolic conditions, or in patients even with acute dermatologic conditions, like in the Stevens-Johnson syndrome, or like in patients with staphylococcal scald skin syndrome or toxic epidermal necrolysis, or in patients with coma, or in patients presenting in shock, or in patients presenting with syncope and collapse to the ground. All these are acute medical conditions which need a rapid decision and which needs a quick action by the practitioner in clinical practice, and it usually presents in the emergency room. And here we have to be more aggressive in taking the decision, because most of these acute medical conditions are critical, and most of these acute medical conditions are life or maybe life-threatening. That is, threaten the life of the patient. So it will be an issue between life and death. So if the physician in charge didn't take the proper decision in the proper time, he might put the patient at the risk of passing away, that is, death, and there might be instance of increased morbidity and increased mortality. If the patient didn't die, he might suffer from increased instance of complications, that is, we put the patient at a risk of a higher morbidity and, of course, higher mortality. That's why we have to be more aggressive in approaching such acute medical conditions. So it depends on the what we call the rapidity of onset, of development of symptoms in a particular case, because as we know, we either approach the case as symptom-oriented or as disease-oriented, and in most of the cases we have to identify the disease, because in reality we are managing a disease, we are not managing symptoms. If the patient is presenting with fever, we have to understand what is the patient of the acute febrile illness or the acute fever. So we have to reach the diagnosis. It is an infection, which is the commonest cause of acute febrile illness, and what is the underlying organism? Is it bacterial? Is it viral? Is it fungal? Is it parasitic? Is it opportunistic infection? Is it a venereal disease? Is it what is the causative agent responsible for the acute febrile illness? If it is infection, for example, or we may search for other causes of fever in cases of pyrexia of unknown origin, or fever of unknown origin, or chronic recurrent fever, like malignant conditions, like endocrine causes of fever, like collagen vascular diseases, like other inflammatory conditions, like some endocrine diseases, like malignancies, as I mentioned, like other non-infectious causes of chronic recurrent fever. But in acute fever, in most of the cases, it is an infectious problem, or what we call acute febrile illness due to an infection. And we have to identify the underlying infection in such cases. So here, this is the, in acute cases, we have to identify it. As I mentioned, it depends on the rapidity of onset of the clinical condition. And I gave an example of this. In acute cases, we have to be more decisive, we have to take an action, we have to be more aggressive in approach, and at the same time to be firm but gentle, as we say. Be firm but gentle. We have not to rush with stupidity and in a messy or haphazard or bizarre way, and then the therapeutic decisions or the management and the therapy of the patient will not be on the proper track or in the proper way. So the diagnosis should be quick, and the treatment should be quick. This is in acute medical conditions, which, as I mentioned, it depends on the rapidity of onset of the development of symptoms. Whether, for example, in acute pain, which is one of the commonest in clinical practice, and it is the commonest symptom presenting in acute medicine, is pain, acute abdomen, acute chest, acute headache, acute back pain, but the most common in clinical practice is the acute chest pain, and or what we call acute chest, and acute abdominal pain, or what we call acute abdomen. And here we have to reach to the proper diagnosis of the cause of acute abdominal pain, and in some cases subacute abdominal pain, but the acute is more urgent and more emergent, and we have to take decision quickly because the patient might be suffering from a life-threatening condition which might be complicated. For example, an acute appendicitis, acute cholecystitis, ruptured viscus, perforated ulcer, paralytic ileus, acute dissecting abdominal aortic aneurysm, acute occlusion, acute vascular occlusion of one of the big abdominal arteries like the superior mesenteric or the inferior or mesenteric or the celiac artery, causing acute ischemic colitis, which might be life-threatening, or any of the other conditions of causing acute abdomen. Same in the chest. When the patient presents with acute chest pain, we have to see it done. But number one is to exclude or to confirm an acute cardiac cause, or versus, on the other hand, non-cardiac causes of chest pain. The cardiac causes, the most dangerous and the most emergent and the most urgent is acute MI, or what you call acute coronary syndrome, whether unstable angina or the acute myocardial infarction, which might be complicated by dreadful arrhythmia, ventricular fibrillation with cardiac arrest, or even acute pulmonary edema due to left ventricular failure, and the patient might die within seconds, drowned in pulmonary edema, or because of an arrhythmia which directly arrests the heart. So these conditions, the cardiac cause, whether acute MI or even acute aortic dissection, which is in the differential diagnosis of acute MI, or acute pulmonary embolism, or acute lung collapse, these are all causes of acute massive pulmonary embolism. They are all causes of acute chest pain, whether cardiac or non-cardiac, which we have to interfere quickly, and the patient must be admitted into the critical care unit or the ICU and quickly receive emergency measures for the proper case. If it is an acute MI, he should receive thrombolytic therapy. If it is pulmonary edema, he should receive the measures for pulmonary edema, up to mechanical ventilation even in some cases, and intubation, and all of these measures which we use in acute pulmonary edema, for example, as a dangerous and life-threatening acute cardiopulmonary emergency. And we have to identify the underlying cause. For example, in pulmonary edema, is it a cardiac pulmonary edema or a non-cardiac pulmonary edema? And this is in order to, because for each one of these, there is a different treatment. Cardiac pulmonary edema treatment is different from the adult respiratory distress syndrome or the non-cardiac pulmonary edema, which is the ARDS syndrome. Which of course is due to many medical and surgical causes. So in such conditions, the rapidity of onset here, there is an acute onset, or even sometimes what we call abrupt onset, and the course is rapid. So it depends on the rapidity of onset of the medical condition and the course of the development and the progression of symptoms. That is, it is acute with rapid course, for example, or abrupt onset with rapid course. Here, this is an acute medical condition which fulfilled its criteria, and we have to approach it quickly. So it depends on the onset, course, and duration. Because most of these acute medical conditions, they are of short duration, different from the chronic and recurrent medical conditions, which usually are chronic, and they are of longer duration, and they have what we call rather insidious or chronic onset of its symptoms. Here, the approach in this one will be, as I mentioned before, conservative approach, but the approach in the acute medical condition, it is a rather aggressive approach. And in such conditions, actually, we have, in the acute medical conditions, which deserve acute medical attention because they are at risk of increased morbidity and high mortality, we have to admit the patient into the proper setting. We have to transfer the patient, take the primary measures in the ER, and then transfer him or her directly to the ICU for better management and for better resuscitation of the case. Because the patient might develop arrhythmias, need a defibrillator, the patient might need intravenous medications, intravenous fluid therapy, central venous line, intubation, all of these things, they should be done. If not done in the ER, they should be done, or they might be done in the ICU. So the patient should be transferred to the proper place, which is the ICU, to take the appropriate measures for such a case. And here, in such acute medical conditions, we have to be active rather than reactive. And we have to be aggressive rather than conservative. So the aggressive approach versus a conservative approach, we have to pay attention to this, and we have to be active, as I mentioned, rather than reactive, that we have not to wait for the clinical complication to occur and then we manage it. This is called reactive. No, the good physician should expect and treat before the development of the pathology and the development of the complications. And this expectant management of the doctor, we call it the active management of the condition, the active management of the case with all its parameters from its pathophysiology. Try to focus on the pathophysiology and to treat it. Don't focus on the symptoms. We don't treat the symptoms unless we do not know the exact pathophysiology. But the best treatment is pathophysiologically or pathobiologically oriented approach. When we put our hand on the pathobiology, the treatment will be better than just managing the symptoms as they develop. So we have to be active rather than reactive, and being part of the aggressive approach of the a clinical case in acute medical conditions or in the acute medical settings. This is the talking about the approaches or the different approach, the acute versus the chronic treatment in a clinical practice, and the what we call the aggressive approach versus the conservative approach in clinical practice, which we should understand, and we should be targeting our management in the proper clinical setting in order to save time and in order to decrease the morbidity and the mortality of the case according to its diagnosis. This is what I wanted to highlight in this my short talk, and all clinicians and physicians working in clinical practice should focus on this, what's the role of the conservative approach and what is the role of the aggressive approach in clinical practice, and when to apply and what is the definition of each one of them. Of course, each one of these approaches needs more details, but I just gave an outline and general principles of the different approaches to patient management in clinical practice as part of clinical decision making, being part of my series on clinical lecture notes. Thank you so much, and I hope that all of you will have a great day, and keep attention and be safe and peaceful. Thank you so much.